and welcome back to the International Chronic Pain Summit 2020. Next up, we have Dr. Deepak Kumar. And Dr. Deepak Kumar is a postgraduate in sports physiotherapy and has a doctorate in manual therapy. He's a founder, director, and senior consultant manual physical therapist at Capri Institute of Manual Therapy in India. He's a certified McConnell teacher, and he is a former Mulligan concept teacher. In the last 28 years of his practice, along with his team, he has over 100,000 patients. And in his 8 days hands-on manual therapy workshops, he has trained over 13,000 physiotherapists from 52 countries across the globe by conducting more than 250 workshops. His book, Manual of Mulligan Concept, is a bestseller in Amazon and is translated into various languages such as Russian, Korean, Chinese, and it's also being translated into Arabic at the moment. He's a successful clinician, academic, researcher, writer, and an entrepreneur. Welcome to the summit, sir. You have chosen to talk about belief systems and manual therapy in the management of chronic pain. Can you start by discussing what do you mean by belief system and what role do they play in our daily life?
Thank you, Devdeep, for having me in this summit. Yes, I do believe in belief system as it play an important role in pain management. I see it as an important component of biopsychosocial model of pain. Let me just start with some examples. In India, on some festive occasions, you will see people piercing their cheeks with hot metal rods, or hitting themselves with the whip, or walking on the burning coal. For you and me, it's a torture. But they feel happy and enjoy doing it. They feel no pain at all, believing their God is getting pleased. One may connect it with the spirituality, but scientifically speaking, this is the belief system actually. Similarly, if you look at the example of a small baby elephant, it's very naughty and very playful. And in order to keep it under control, its master would tie his feet with a thick rope to a strong tree. And no matter how hard baby elephant try, he cannot break it. And then over the time, after several attempts, repeatedly, for weeks and months, it gives up. And he starts to believe that it is not possible to break that strong rope. And then when it grows to become a big elephant, the master would just tie him with any rope to any small pole. Now, if this big elephant gives even a small gentle pull, the rope will come out with the pole. But do you think the big elephant tries to break it now? No. Because he believes that it's not possible to break it. So it's the belief system that makes an individual to believe in his or her immense capabilities of doing certain tasks or activities. This is what the belief system is. It can break you or it can make you. You can be strongly mental or mentally strong. You can have hopeless end or endless hope. Let me tell you that belief system is the feeling of assurance, the feeling of certainty, the feeling of permanence, and the feeling of rigidity. And the belief does not get built up just like that. It gets built based on your past experience. That could be a good experience or a bad experience. And if the past experience was good, for example, if you were walking and you fell but didn't get injured, so when next time you fall, you won't get worried because you will believe then nothing is injured. And probably you will continue with your routine work. But if in the past, after fall you got fractured, so next time, even if you have a small fall, first thing you will get done will be an X-ray. Because in your previous experience, you had a fracture after the fall, while you might be absolutely fine. And there is actually a sequence for formation of the belief system. Firstly, there should be a logic or some event behind it, some reason or some experience behind it. Again, that could be a happy or a sad event. So firstly, there has to be a reason or the past experience behind it. Based on past experience, there will be a formation of feeling or emotions. And then over the time, with alike experiences, the feeling gets more stronger and become more rigid. And you start making opinions about it. And when you share these opinions with your friends and relatives, they also contribute with their past experiences and opinions. That lead to convictions. And now, when an expert confirms the same opinion as yours, then it lead to feeling of permanence. That could again turn into massive belief if multiple people around you have similar opinion. Similarly, in our daily life, if someone share a bad experience about a certain place, you tend to take extra care when you go to that place, even if there is nothing wrong there.
That's really interesting. Thank you. That's some really good examples there. So there's been the biopsychosocial model is the currently accepted model of understanding of chronic pain. So what you're talking about, belief systems, does fit, I think, into this model. But what role do you think the belief system or the beliefs play in the development of chronic pain?
Yes, the belief system is one of the very important component of biopsychosocial model of pain management, which is not a very old practice worldwide, but in India it's being practiced since ancient time. In its own style though. The belief system in India is so strong that if someone is getting any problem or has pain or not getting cured, they go to temple, to their gurus or someone elderly in home to receive their blessings and traditional remedies. While giving blessings and traditional remedies, gurus or elderly also assure that the person can be relaxed because it's going to be all fine. And the person has all the reasons to believe in because of the positivity and the aura present in and around that area, making him believe easily that he or she is going to be fine for sure. So along with medical help, they also receive psychological support in form of positive beliefs. And it's not only the patient, but also his society, including family members, colleagues in the workplace, relatives, and friends also believe the same. Help patient further by motivating him, saying, yes, it is possible. And then the feeling becomes conviction. And patient gets settled faster in his society and routine day-to-day life. Now, in its own way, don't you think it's very much fits into biopsychosocial model of pain management? Remember, you are an average of 5 people you interact daily in your life. So what people around you think about a certain condition or disease, what is their opinion about it, how they behave towards it, will also affect your behavior towards that disease. Research says that lifetime prevalence of low back pain is 80%. And in India, we have population of more than 1.3 billion. Now, can you imagine how many people shall be having back pain? And do you think they all are going to the clinician for the treatment? Certainly not. Probably not even 10%. So what is happening to remaining 70%? Many of them are getting treated in their own way, either by the traditional method or going to someone they believe in. Many of them do get help, and it's been happening since ages. Of course, not to forget that many of them will also recover without any help or treatment. After any trauma or jerk or pain in his spine, when someone Google back pain or discuss it with their friends and relatives, and when they share their story of slip disc, patients start visualizing disc prolapse or spondylitic changes in his spine, which eventually get confirmed after getting MRI scan done and leads to formation of conviction and permanent belief that Now he cannot be good as he was before. And unfortunately, some clinicians also confirm the same. While as reported by Rinjikji et al. In 2014, those findings might be just an incidental finding. But unfortunately, the person will develop negative belief about his back pain and may not respond to any treatment. Now, because of this conviction, their way of standing, sitting, walking, sleeping, working starts getting changed.
So you do believe that negative beliefs can perpetuate the intensity of chronic pain and the feeling of disability?
I would begin by saying yes. A certain negative beliefs towards that condition would not only increase the intensity of pain, it would also increase the duration of suffering. And more the duration and intensity of pain, more would be the feeling of disability. I would give you a classical example of patient with knee osteoarthritis. When they are diagnosed with these age-related changes, which may be normal according to their age, but they tend to perceive it as a medical condition and start worrying about it. They Google their condition and start getting influenced by the experience and opinion of the society available on net, which compel them to build up certain beliefs that they need to avoid certain specific movements and activities, and hence start protecting their joints from stress and strains by avoiding stair climbing, walking, or knee bending, which lead to further muscle imbalance and the tightness of various tissues around the joint, hence altering the normal biomechanics, which in turn prevents the person from doing his or her basic activities of daily living and increase their level of dependency on their family, and further increasing the feeling of disability.
That's interesting. Okay. So would you say that you've used belief systems as a coping strategy and a mechanism for developing positive mindset in patients?
Yes, I have been practicing it since almost last 28 years. In 1992, I got 2 case studies published on hypnophysiotherapy in Indian Journal of Physiotherapy. What I did was that I put the patient having right hemiplegia in trance and gave him positive suggestion under trance, dealing with his subconscious, and then asked him to raise his right arm, which he was not able to lift before. To my surprise, he could lift it to some extent, and over the time, after few sessions of hypnophysiotherapy, he was able to lift his arm comfortably. Similar observation was also recorded on another subject who had tendon transfer for foot drop. Because we know brain knows movement, not the muscle action. So I gave muscle stimulation under trance, and the results were amazing. Under trance, it was easy for the person to believe that they can do it. Now here I created a positive imaginary of their movement and created a positive mindset to the patient. And that's why I achieved a desirable result in a short span of time.
Hypnotherapy and trance. That's really interesting, and that sort of makes me think that we can go in so many different ways in terms of forwarding this discussion. But I think I'd like to just focus back on pain again. So if I could get you to talk about pain and what is your understanding of pain, and do you think it is bad? Do you think it is good? What is your perception of pain?
Pain is your friend, not your enemy. It shall be acknowledged rather be ignored. And one need to do something about it. It tells you there is something wrong in the body. It is the alarm system of our body. Moment you get injured or hurt, it starts paining, so that you can take care of it. Imagine a patient with diabetic foot. There is reduced or no sensation, right? And while walking, and if a nail pierces their foot, you won't feel pain. An injury will go unnoticed. resulting in heavy bleeding. And by the time he comes to know about the injury, it may become too late and he may have to lose his foot. So, the pain is your friend, not your enemy. It tells you there is something wrong with the body.
Yeah, so just thinking about that a little bit further, in terms of pain management with manual therapy, do you think that you are just providing symptomatic relief, or are you trying to address the cause of the pain as well?
Of course, before deciding treatment, one has to find the cause behind it. And being a physical therapist, we have to find the physical cause behind it. Remember, medicine can change physiology, not the physics behind it. And we, being a physical therapist, we have to treat the physical cause behind it. Now, in the present era of extended scope of practice, we probably also have to find not only the physical cause, but also the psychosocial component behind the pain. Let me ask a couple of questions here. Imagine a constant seepage in bathroom due to crack in some pipe. Okay. So would you keep mopping it after every hour? Or will you call a plumber and get it fixed? Of course you will call the plumber and get it fixed. So without treating cause, one cannot fix the pain on long-term basis. Now here it is important to note that the cause could be inside the body or could be outside. Means the belief system associated with the pain, the psychosocial component I'm talking about.
That's interesting. Okay, so in terms of chronic pain, I guess if we think about it a little bit further, if the patient doesn't recover with your initial manual therapy intervention, would you then start to do a further detailed assessment or reassessment, so to speak, to consider the alternative source of pain? You could understand what is perpetuating the pain, what is enhancing the pain, what could be the contributing factors. So would you do a reassessment?
Yes, absolutely. Clinician shall re-examine patient if patient is not recovering within stipulated time period. And I would like to put it like this. Imagine you are driving a car and it is wobbling. So you go to a car mechanic and he changes the engine oil. Do you think the wobbling will stop? Absolutely not. Because the problem is with the alignment of the wheel and has nothing to do with the engine. Means the problem is elsewhere and it is getting treated for something else. So until unless you get those alignments corrected, it won't go in a straight direction. Similarly, in order to fix the problem, one must find the cause and its site. For example, if the foot is overpronated, so the talus goes down and in, and the tibia goes in, inside the internal rotation, and then eventually femur also goes into internal rotation. And then obviously the biomechanics of the hip joint and the sacroiliac joint get altered. We all know that. And in this case, all treatment for sacroiliac joint or lumbar spine will be temporarily only, until unless you fix the entire chain starting from pronated foot. So while it is important to have a detailed local examination, it is also important to examine patient globally to find the exact cause behind it. And while doing reassessment, you might also come to know about red flags and the yellow flags which might have been missed in previous examination and hence getting no result. And to understand the illness, one must have good communication skills, patience to listen patient, and always ask open-ended question rather close-ended one. So you get to know everything related to patient illness, including associated psychosocial component.
Right. So, in terms of manual therapy, one of the other things obviously is provocative testing. So, you do a lot of provocative testing. Could you elaborate on the role of provocative testing on assessment of pain?
As a practice, yes. If not always, but majority of time. Let me share some of my insight on it. I'm sure you must have realized many times that all those provocative tests are designed in such a way that either it is compressing the affected structure maximally or stretching it maximally. Especially in case of mechanical pain, And since my background is from orthopedic manual therapy, so I try to see every problem from mechanical point of view. And I often tell my students that any neuromusculoskeletal pain, please note, I'm not talking about visceral pain here. So, any neuromusculoskeletal pain, if can be provoked, will get provoked either by maximum compression or by maximum stretch. So while doing provocative test, you are either compressing it maximally or stretching it maximally to provoke pain. And in case, the pain is neither increasing nor decreasing because of these compression or stretches, means probably it is not a mechanical pain. So think of red flags or psychosocial component associated. I believe it is the responsibility of the clinician to find out the source of pain, no matter if it is pathological, mechanical, or psychological, or due to certain belief. And you can easily find it. If you have good art of communication, have patience to listen to patient, and you will come to know many things which maybe in your earlier assessment you or the previous clinician might have missed out. One has to build a rapport with the patient to get connected, and then you come to know many things which patient might have not told you otherwise. So not only the provocative test, it is also important to make sure that one develop a good rapport and get connected while doing the reassessment.
So as you said, your focus has been on manual therapy and the physical element of pain over the years. Tell us a little bit more about your clinical practice over the years and how you have used a combination of manual therapy and reinforcement of positive belief, enhancing the positive belief in order to achieve the positive outcomes that you have so far.
As I said, my background is of an orthopedic manual therapist. So I try to see everything from physics point of view. And similarly, I see pain from biomechanical point of view. Treating patient with manual therapy would help them to reduce their pain and remove the cause behind it by correcting the positional fault or your faulty biomechanics. And to have long lasting result, we also need to change their belief system towards their pain. And to achieve these goals, one shall also educate the patient in simple way about his problem and the biomechanics behind injury and the treatment. Therefore, patient may become aware about the importance of the mobility, strengthening, corrections of the positional fault. When patient visits us and I treat them using manual therapy, I make sure I give a glide in such a way that offending movement become pain-free and give only positive command as a part of communication. While delivering manual therapy, like, what I say, if it is comfortable, please move your arm. And when patient realize it is easy to move without pain, his belief system starts changing. Here, did you notice, instead of saying move your arm if it is pain-free, I said move your arm if it is comfortable to you. The pain, the word pain is missing here. Because the moment you say pain-free, patient start looking for the pain in affected area. And what you search in your body, you get that. And it becomes difficult to abolish pain from their body, that too against negative belief system. On similar line, while greeting the patient on his arrival, never ask, how is your pain? Rather ask, how good you are. So along with manual therapy, you are not only correcting the positional fault, increasing mobility of joint, providing nutrition, stimulating proprioceptors in and around the joint, creating a strong neurophysiological effect to reduce pain, but also changing the belief system into a new belief system. That yes, it is possible to get rid of pain. It is possible to be healthy, fit and fine again. After manual therapy, when patient feel remarkably better, the new feeling comes in. New opinions start building. And obviously, now new positive convictions are in place. So the way you develop negative belief system, in same way, one can also develop new positive belief system as a part of treatment. So this is how the manual therapy work in managing the pain along with the belief system. So in an integrated approach, using manual therapy can be really beneficial to bring about these positive mindset, educating the patient and instilling positive beliefs that they can overcome pain and disability to regain their control of their life. And remember, if the only tool you have is the hammer, you tend to see all the problem as in nail. That means thinking in one direction won't help you. You need to have multi-directional, multifaceted approach to take care of every aspect of pain. The biological aspect, the psychological aspect, and of course the social aspect, especially to treat the chronic pain.
One of the criticisms that's been highlighted against manual therapy is that it promotes dependence, and that the patients come to the manual therapist for a quick fix rather than developing their own self-management strategies, developing their self-management tools, and therefore it promotes dependence and rather than them having greater control of their own pain. And obviously there is evidence around the lack of effectiveness of manual therapy as well, especially for chronic pain conditions. What would you say to that?
Sorry to say, but I disagree with those friends of mine. I don't see that manual therapy promote dependency, because majority of techniques and procedure can be taught to patient in a very easy way. And during this lockdown period, we did tremendous amount of work by doing online consultation and treatment. We taught them how to do self-mobilization of their affected joint, and the results were awesome. Once the patient learn and master the right way of doing things, why he or she should be visiting physiotherapist again and again. Moreover, whenever required, he or she can fix it by themselves. I would say there are enough published articles in various reputed journals in support as well as against manual therapy. In last 28 years of my practice, me and my team have treated more than 100,000 patients, and many recovered in single sitting after manual therapy. And if after manual therapy, patient claim to be 70 or 80% better or feeling no pain immediately or after weeks, they are fine. What do you want me to tell them at that time? That sorry, actually there is no strong evidence to support manual therapy, therefore I don't trust you saying that you are fine. You are telling me lie and you still have the same pain. Do you want me to say those things to the patient? Anyway, it's up to the clinician to decide which one they wish to believe in. And as you said, yes, it's true. Whenever we talk about positional fault theory, some of our friends do start talking about evidences to support it.
No, I get that. So I guess the question then is, you've generated a lot of evidence from your own practice as well. So if you've treated over 100,000 patients, you've generated a lot of evidence. But from your talk, should we understand that you don't believe in evidence-based practice? You believe more in your own practice and what you've done and the evidence that you've generated from your own practice?
No, I'm not against evidence-based practice. Rather, I support it and do follow the same, but not blindly, because we must decide to what extent we shall follow it. And on which evidence or research shall we believe? As every now and then new concepts emerge and go. Initially there were enough evidence that in acute case or injuries, RICE regime works. And as we all know, RICE stands for rest, ice, compression and elevation. Later evidence came, no, it's actually the price that works. So the protection P was added in RICE, making it price raising. And then the evidence came for pricer, where the referral was added in the and, making it pricer. And by the time one just thought to start practicing it, a new research got published that says no, there is no evidence to support it. But it's the police that works, which stands for protection, optimal loading, ice compression and elevation. Here the rest component is replaced by optimal loading. Does that mean that the RICE protocol, which included rest and followed for many years, was not effective at all? Now, as a practitioner, one may feel cheated because since last 30 years, as per his experience, he was already practicing polish and was forced to shift to price, as many others criticized and laughed at him for the same, blaming for not practicing evidence-based practice. We all know necessity is the mother of all invention. Means all researches are based on necessity. However, intention behind it could be good or bad, because many times researches are either funded by developers, equipment manufacturers, special interest group or pharma companies. Many a time, research is conducted to prove or disapprove a theory that came in the mind of the researcher. And it becomes difficult to digest, at least to me, that research will be unbiased, no matter how hard the researcher may try or conduct a double-blind RCT. Eventually, majority of time, result will support the hypothesis planned by the researcher. Now, please tell me, how many published articles have you seen where null hypothesis was accepted? Maybe extremely few. So, was it not that researcher only proved what he wanted to through his so-called research and created evidence for the same? And then in the name of evidence-based practice, everyone starts following it. And then over the time, new research get published condemning the previous one. Also, one may agree that the outcome of the research also depend on the qualification, background, clinical skills of the researcher, and the ability to interpret results. And if the research is funded by industry, there might be hidden conflict of interest, which might also affect the outcome of the research published. Now tell me, shall I believe in more than 28 years of experience of mine based on 100,000 clients treated using particular technique or protocol that worked in more than 80% of the cases? Or shall I trust a published research conducted on maybe just merely 100 subjects? That too in some other geographical location, on some other ethnic group, having different eating habits, lifestyle, belief system, having different psychological, physiological, genetic factors, and acclimatized to different climatic conditions. And remember, these are in addition to the anatomical variation we all individuals have. It is important to note that some finding might be statistically significant but clinically irrelevant, and vice versa as well. That is, it might be clinically relevant but statistically insignificant. Please note, practice-based evidence cannot be neglected. In fact, if one takes a closer look, it is also included within the classification of evidence-based practice, though at a lower hierarchy, of course. Therefore, clinical experience is also an important determinant which forms the basis of successful evidence-based practice. So it is up to the clinician and patient on whom they should believe. Only evidence-based practice or only practice-based evidence or both. I believe in both because you will always get articles supporting or against manual therapy. It is up to the individual to decide. I believe in manual therapy and I also believe in biopsychosocial model of pain. I mobilize my patient not only to treat them biologically but also to treat psychologically and treating the cause not from the body but up from here as well, and then sending back to his society for his routine lifestyle.
Okay, that's interesting. So one of the other things that I'd like to ask you is, I've seen the role of physiotherapists change over the years that I've been practicing, and moving on from more of a treatment provider and hands-on consultant to more of a guide, a coach, a mentor, empowering the patients. That's our focus, is to provide them with the self-management strategy so they can take away the things and action them at home independently. What do you think about that?
In my belief, physiotherapy is not only a science but also an art. I believe physiotherapists treat their patient 50% by physical means, that is your manual therapy, electrotherapy, or whatever, and remaining 50% by effective communication. I also thought of a physiotherapist as a counselor, and in the current era of biopsychosocial model of pain management, it is really important for the physiotherapist to understand the extended scope of practice. But at the same time, occasionally to your dismay, might be the problem is in such an advanced stage that you shall be referring the patient to a clinical psychologist or to a social worker or a specialist in that particular field. It is always a teamwork, you know. You fix the physical cause of the problem, but in case you have to handle the infection, take the help of a medical professional, and for the psychological component, take help of a clinical psychologist and work like a team.
Yes, that's true. I think that's definitely the case. So that's perfect. Thank you so much for giving your time for this talk, having this conversation with me. I think it's been very interesting. There are some challenging thoughts in there, certainly, but I think we do need to explore our views and understand our own sort of stance, to be able to move forwards in our professional career. So thank you so much. It's been lovely talking to you.
Thank you very much, Devdeep for having me in this summit. I'm sure it's going in a beautiful way and participants are getting benefited. Thanks for organizing such a lovely e-summit. Thank you so much.